Hello, my name is Sam Bunzli, and I'm a postdoctoral researcher at Opus, based at the University of Melbourne in the Department of Surgery at St Vincent's Hospital. It's my pleasure to present in this session on emerging research themes. Now, in my talk today, I'll outline the background, rationale, the aims, methods, and proposed outcomes of a new Opus project, changing public perceptions about osteoarthritis. So over the last couple of days, we've heard a lot about high-value osteoarthritis care and what that looks like. So as a postdoc at Opus, I've been adopting a cognitive behavioural perspective to investigate uptake of high-value care among people with osteoarthritis. Now, one of the very early studies that we did within Opus was a qualitative study in which we interviewed people on the waiting list for joint replacement surgery, and we asked them about their pathway to surgery. What we found was a really poor uptake of high-value care along that journey. We found that people's treatment choices along the pathway seemed to be driven, at least in part, by misconceptions or myths about osteoarthritis. So the people in our study reported that once they had heard that they had bone-on-bone changes in their knee, so they had no more cartilage in their joints, which they perceived was due to wear and tear or years of loading through their joint, they avoided activities that they felt would increase the loading and cause further damage to their joints. People felt that a total joint replacement was really the only solution to fix osteoarthritis and to cure pain. So as soon as they had heard those words, wear and tear, and that loss of cartilage, they perceived that a joint replacement was going to be inevitable at some point down the track. In a subsequent study, we explored patients' reflections on the knee replacement journey in patients who were 12 months post-operative. We selected people who had a range of scores on an expectation measure, which they had completed pre-operatively 12 months ago. And all the participants in our study described instances where their anticipated and their actual experiences diverged, specifically around their anticipated versus their actual functional outcomes and the length of the recovery period. About half reported being told by their surgeons that the recovery period could be difficult and that their expectations of pain relief and the restoration of function might not all be met. But despite this, high expectations that a brief recovery period would lead to a resolution in pain really persisted in this sample. And there's a quote here that captures this nicely here. The surgeon told me that the knee isn't one to take lightly. I went into it thinking, well, I've been warned about this, but I didn't take it in. I knew this is what I needed, and I had high expectations about the outcome. Now, a limitation of those findings was the retrospective design of the study. We were relying on the recall of people post-operatively. Now, more recently, in a study led by Opus PhD student Miles Devaris, we've been collecting prospective data with people referred for a joint replacement consultation. So each participant enrolled in the study has data collected at 3 points in time. The first being an interview pre-consultation. And then the second data collection point is a video recording of their surgical consultation. And the third data collection point is a follow-up interview 1 week later. And what we're observing from our preliminary analysis is that patients attend the consultation with strong beliefs and expectations about joint replacement. And these don't seem to really change through the course of that consultation. The patients seem to be only taking away from the consultation the information which overlaps with their pre-existing beliefs. So where are these pre-existing beliefs and expectations coming from? In considering this question, we have taken a novel approach and looked to discourse theory. Now, according to discourse theory, our beliefs and expectations are shaped by the way we talk about our health, known as our health discourses. So we ask the question, how do people talk about osteoarthritis? And we use discourse analysis to identify patterns in the way people talk and to consider how these ways of talking construed meaning relating to osteoarthritis. So we applied these discourse analysis techniques to a data set of quotes that we had extracted as part of a qualitative systematic review. This review involved 64 studies with people with knee osteoarthritis and their clinicians. And our analysis revealed an overarching impairment discourse, which was the dominant discourse observed in all the studies, And we also observed a less dominant, coexisting, overarching participatory discourse. So people who used an impairment discourse thought of their bodies as machines. They used mechanical analogies to describe the loss of cartilage in their joints and used phrases such as the brake pads are worn out. My joints are like an unoiled engine that is seized up. And just like those inert car parts, bones can't regenerate. And there's little people themselves can do about those damaged joint surfaces, other than to avoid activity so as not to make that damage worse. The only real solution is to seek out a mechanic to fix that broken machine. So people make comments like, I believe in nuts and bolts. If something's worn out, you pull it out and you put a new part in. Now, according to this impairment discourse, the body, like any other machine, comes with a use-by date, after which time it's not considered safe to use. And while some people use their joints more than others over the course of a lifetime, there's a sense of inevitability that one day that use-by date will be reached. So this also gives way to beliefs about osteoarthritis being a normal part of aging, and that people just have to put up with it until it's severe enough to warrant a joint replacement. Now, people who used a participatory discourse, on the other hand, tended to see their joints as more than just cartilage and bones, but rather as structures that were cocooned in muscles. Now, unlike cartilage and bones, muscles can regenerate. They're visible to the eye and they're under voluntary control. So by building up muscles, joints could become stronger. And healthy joints were perceived to be joints which enabled people to be active. So a joint could show signs of osteoarthritis, but still be perceived to be healthy. So people who used this discourse shifted the focus away from only addressing pathoanatomical changes towards what they could do to be physically active and to keep participating in life activities. So this participatory discourse appeared to be more consistent with the clinical practice guidelines, and that it encouraged people with osteoarthritis to continue engaging in physical activity, unlike that dominant impairment discourse, which discouraged people from engaging in activities that loaded their joints and appeared to shape expectations around surgery being the only cure. So by changing the way people talk about osteoarthritis, could we then change people's beliefs about the role of physical activity in joint health? And in doing so, could we encourage more people to be physically active and less reliant on doctors to fix their joints? Well, the way people with osteoarthritis talk is shaped by the health discourses in their broader social context. So even before we experience the onset of joint pain, we've already developed ways of talking about our body and joints. So an important next step for us is to understand the public discourse around osteoarthritis and to consider how this public discourse aligns with what we know from the science. So aligning the public discourse with the expert or the scientific discourse is an important objective of behaviour change public health campaigns. You can think of how sort of slip-slop messaging has shifted our language away from that idea of a healthy tan. So Opus researchers have come together with an expert in linguistics and health communication, Professor Robin Woodward-Cron from the University of Melbourne. And we have developed a research theme, which is looking at how Australians talk about osteoarthritis. Our specific aims are to explore personal discourses around osteoarthritis. So how do Australians talk about osteoarthritis online and in person? We want to explore public discourses. So how is osteoarthritis framed in the Australian media? And we're exploring expert discourses. So how is osteoarthritis framed in policy and practice guidelines? And based on these findings, we aim to develop a communication framework that can inform a future public health campaign that can change the way Australians talk. So we'll explore personal discourses through analysis of social media posts on Twitter, Facebook, and health forums. And we'll also be conducting interviews with diverse people across Australia, including people from culturally and linguistically diverse backgrounds. We're exploring public discourses through analysis of industry messaging on television ads, as well as digital news media, and then exploring that expert discourse through analysis of health policy documents and practice guidelines. And then drawing on Professor Woodward-Cron, who has expertise in discourse analysis, we'll be looking to apply some of those principles of discourse analysis to identify patterns in the way people talk to consider how those patterns construe meaning, and then have a look at analysing the extent to which these patterns align. So ultimately, outcomes from our work may reveal new ways for health messaging to change the way Australians talk about osteoarthritis and to help direct resources to where the greatest needs lie. Our findings may contribute to debate on the role that the media plays in public health discourse and determine if any regulatory action is needed to manage industry messaging around joint health and osteoarthritis. Our findings may reveal the extent to which joint health is prioritised in Australian health policy. It may provide or it may inform how health discourses can be tracked over time through, for example, ongoing analysis of social media data. And we hope our findings are going to inform how clinicians can communicate better with people with osteoarthritis. And finally, we anticipate that our study can also help build capacity in orthopedics through interdisciplinary training in qualitative research methods, applied linguistics, and health communication. Thank you very much.